national
We are
chairman
live, sir.
and
We are
urologist
live,
के
sir.
national chairman.
हेलो
We are
यार,
live.
क्यों क्यों झाड़ पे चढ़ा रहे हो यार?
Now the webinar has been,
Right, sir.
the webinar has become national now. It's not based on.
He joined last.
We are live, sir.
We are live. Okay. Kishore and Mukund, can you please start? Yeah.
Good evening, all respected teachers, seniors, and my dear friends. It gives me immense pleasure to present in front of you this webinar on ureteroscopy. Basically, this is the initiative of educational initiative of West Zone USI, and we try to make it more practical, which will be helpful for the PGs for their exams as well as the junior consultants. Of course, it will give tips to the all practicing urologists as well. So first of all, I'll thank Dr. Mukund Andankar sir for taking this task as a moderator, and he has the person who formed this program one month back, and he really worked hard on that. I also thank Dr. Prashant Manokar to suggest the name Upbeat Ureteroscopy for this webinar. So thank you so much and welcome all. We'll try to make it as practical as possible and try to finish in time. I request all the speakers to finish in time so that the question answer will have some time at the end. So now I request Dr. Rajesh Supriya, Honorary Secretary, USI, West Zone USI, to speak about. Over to Rajesh.
Yeah. So welcome all delegates and all postgraduate students. Welcome all to this second part of our online series for postgraduate training program. We had a first webinar on BPH, which was very well conducted by Dr. Sable and Dr. Subodh Shivde. And I hereby, first of all, would like to thank Dr. Kishore Vani and Dr. Mukund Andankar for sparing their time and drafting this excellent practical program. They've been working on this for the last 1 month to make it as practical as possible. And the purpose basically here is to address all the issues and train the practical points to all the postgraduate students and the young urologists who are in their learning phase for ureteroscopy. And I request all of you to please be ready with questions. You can put it in the chat box so that we can address them. And thank you once again, Mukund, and thank you all the faculty, Abhay and others, and for taking part for training all our young urologists. Thank you very much. And so I would like to hand it over to our president, Dr. Ashish Patil, who can then declare the meeting on, and then Kishore can take it forward. Over to you, Ashish.
Yeah, thank you, Dr. Rajesh. I welcome all the postgraduate students for this excellent activity which has been organized by Dr. Mukund and Dr. Kishore. This is one of the part of the educational series started by the West Zone. I would like to thank all the faculty who have put in all their efforts to get this to the maximum beneficial level possible for the students. At the same time, I would like to thank the council who has really grown this small idea which was floated in the council meeting to a large-scale educational activity. Without much wasting much time, I would like to declare this meet open and hand it over back to Kishore for the proceedings.
Thank you, Mr. President, for these kind words. Basically, we are going to finish all the lectures and then we'll take question answers at the end. Whatever questions any delegate have, they can type in the live chat box on the YouTube live, and then we can take them at the end. So now I hand over to Dr. Mukund Andankar sir for further proceedings. Over to you, Mukund sir.
Yeah. Thank you, Kishore. At the onset, let me thank West Zone for giving us an opportunity to moderate this webinar today. We have a very young, dynamic urologist from all the states of West Zone representing our West Zone for this webinar. And we will be discussing very practical aspects of ureteroscopy, a procedure which we do every day in and out. So without wasting time, let me invite our first speaker for today, Dr. Mekhla Naik. He's Associate Professor at Goa Medical College. Mekhla, you're on. She'll be speaking on indications of semi-rigid ureteroscopy, instrumentations, and setup.
Good evening, everyone. Am I audible?
Yes, yes.
Yeah. Good evening, everyone, all faculties and colleagues. I'm Dr. Mekhla Naik from Goa Medical College. My topic for today is like an appetizer for this feast of ureteroscopy. I hope I do justice to this topic. So I'll be talking on certain nuances of semi-rigid ureteroscope. Starting with the relevant anatomy of the ureter, both ureters are paired organs in the retroperitoneum with an average length of 22 to 30 centimeters and caliber of 1.5 to 6 millimeter in the adults, which is conventionally divided into the proximal, middle, and the distal ureter, or the abdominal, pelvic, and the intramural portions. The ureters begin posterior to the renal vessels, close to the renal hilum, and lateral to the transverse processes of the lumbar vertebrae. And the right ureter starts posterior to the second part of the duodenum, and it descends posterior to the ascending colon, cecum, appendix, and the terminal ileum. Both ureters lie just anterior to the psoas muscles and pass over the genitofemoral nerve and under the gonadal vessels. The left ureter also passes behind the inferior mesenteric artery in close proximity. The peritoneum covers the ureters anteriorly until they enter the pelvis, after which at the level of the ischial spine, the ureters lose their peritoneal layer and become completely retroperitoneal. The ureters further descend medially towards the bladder and pass anteriorly to the obturator neurovascular structures and posterior to the obliterated umbilical artery. In males, the ureter pass behind the ductus deferens, and in females, the ureters pass under the ovarian and the uterine vessels. In both genders, the ureters enter the bladder wall at an oblique angle. The caliber of the ureteral lumen varies along its course, with average ranging from 1.8 to 3 millimeters. And the three main areas of anatomical narrowing which are important during an endoscopic procedure are the uretropelvic junction, the pelvic brim at the iliac vessels, and the uretrovesical junction. The uretrovesical junction being the narrowest of the all. The abdominal ureter starts curving medially at the level of the L5 vertebrae. A symmetric medial deviation of the ureters at this level is considered a normal variant. However, deviation medial to the pedicles is considered abnormal, and likewise, lateral deviation of the ureters greater than 1.5 centimeter from the transverse processes is considered abnormal. There could be certain physiological areas of narrowing in the ureteral lumen, like normal peristaltic movement. And also at the levels of L3 and L5, there could be an anterior oblique extrinsic narrowing, which is likely due to the gonadal vessels. Similarly, as the ureters enter the pelvis, there is a extrinsic compression by the iliac vessels, which can be seen. Kinks can appear at the uretropelvic junction during respiratory excursion because of redundancy of the ureter. Within the bladder, the obstruction because of an enlarged prostatic adenoma can cause anterior displacement of the ureter, causing a J-hook deformity. Also, deviation of the ureters can be seen due to presence of a bladder diverticulum or a large cystocele, causing herniation of the ureters into the inguinal region. So, the components which are required to carry out a rigid endoscopic procedure have been the telescope, along with the working channels for irrigation and instrumentation, a light source, and optics to convey the image, and a camera system to capture the image. Harold Hopkins had replaced the thin relay lenses of the older endoscope with contoured glass rods. This caused a reduction in the image distortion and a wider viewing angle. And the transmission also was improved by 9-fold. And the outer diameter of the endoscopic shaft was also reduced. Rigid ureteroscope with working channels were manufactured. However, there was an intrinsic issue with these scopes, that any uh, uh, deviation of the scope from being used in a straight line that could occur because of the application of torque to the shaft could lead to misalignment of the rod length setup and permanent disappearance of up to half of the image, called a half moon or a crescent shaped defect. The fiber optic imaging led to the development of the mini scope or the semi-rigid ureteroscope, combining smaller working channels and fiber optics, allowing both illumination and image to be incorporated into a metal sheath. The optical system was reduced in size compared with the rod lens design, causing overall reduction in the outside diameter of the scope. The flexibility of the fiber bundles also allowed the shaft of even the rigid endoscopes to become somewhat flexible without causing any image distortion. The semi-rigid endoscopes allowed a flexure of almost 2 inches of the vertical axis without causing any image distortion. The chance of breaking the semi-rigid endoscope is much less than what is encountered while using the rigid endoscope, and hence fiber optic semi-rigid ureteroscopes have largely replaced the rigid rod lens ureteroscopes. In general, the tip of the semi-rigid ureteroscope ranges from 4.5 to 10 French, and the smallest of the ureteroscopes preclude ureteral dilatation before ureteroscopy. The shaft of these endoscopes gradually increase from the tip back towards the eyepiece, resulting in a proximal shaft size ranging from 7.8 to 14 French. This taper design increases the proximal strength of the ureteroscope and also helps to dilate the ureter gradually as the endoscope is passed. The scope should be able to navigate the changing caliber of the ureter with areas of the natural lumen reduction, because the caliber of the ureter at around the iliac vessels is about 12 French, and at the vesico-ureteric junction is somewhere between 3 to 10 French, and some areas of potential pathological narrowing also. The working length of most scopes is more than 31 centimeter, which is adequate enough to reach the pelvis in females. However, in men, longer scopes, which should be more than 40 centimeter, are required. The working channels can either be there could be either a single large working channel allowing both irrigation and instrumentation, or two separate working channels, and the cross section of the ureteroscope can be triangular or oval. The earlier fiber optics within the ureteroscopes produced an image which is graining, called the honeycomb effect, because of the or the Moir effect. These fibers were also disposed to fracture with wear and tear, and the water could leak into the lens, compromising the image quality. Thus, even though the inclusion of the fiber optics was critical in the development of flexible ureteroscopes, it also contained inherent engineering limitations. The development of advanced cameras enabled the urologist to remove the honeycomb pattern using the Moir effect, and the flexibility of the fiber optic fibers also allowed the manufacturers to produce ureteroscopes in which the fiber bundle was angled within the endoscope, so that there was a straight channel for the passage of rigid instruments. The newer CMOS and CCD type of sensors are small and powerful enough to be placed at the distal tip of the flexible ureteroscope, obviating the need of any fiber optics and allowing transmission of the images in a digital format, leading to a crisper and cleaner image as compared to the analog video. To achieve optimum light transmission, the fiber bundle diameters of the endoscope and the fiber light cable must be matched to each other. Otherwise, they can cause either excessive heating or a reduced light output. In China, Sun has manufactured a flexible rigid combined ureteroscope with combining the rigid shaft and a flexible tip. There are certain limitations of the semi-rigid ureteroscopy, that there is limited access to the pilocalcial system and sometimes even to the ureter. The use of the rigid ureteroscope with an increased diameter requires dilatation of the ureteric orifice, and this implies passing a stent, and hence there is an increased morbidity, and certain pathological changes like a cystocele or a prostatic adenoma may limit the retrograde access to the pelvic ureter, and limiting sometimes the rigid ureteroscopy can cause proximal migration of a ureteric calculus, and obviously because of the rigid ureteroscopes are bulky and the robust accessory instruments that are used with this, there is an increased incidence of upper urinary tract traumatic complications with rigid ureteroscopes. So for the benefit of PGs, there is a exhaustive list of indications of therapeutic ureteroscopy, including extraction of ureteral calculi regardless of their location, treatment of Strain-Strasser syndrome after extracorporeal shockwave lithotripsy, endoscopic treatment of superficial tumors of the upper urinary tract in certain selected cases, and endoscopic treatment of intrinsic or extrinsic ureteric stenosis, for which cold knife incision, electroincision, acusized balloon or balloon dilator or laser can be used, and endoscopic treatment of stenosis of the pelvic ureteric junction, that is endopilotomy, and extraction of intraureteral foreign bodies like retained stents or retained sutures of endopilotomy stent. Certain selected cases, rigid ureteroscope can be used for treatment of pilocalaceal stones and calaceal diverticuli and intradiverticular lithiasis. However, the flexible ureteroscope has superseded the semi-rigid ureteroscope in these cases. Now, indications of a diagnostic ureteroscopy, it to find out the etiology of a lacunar image at the level of the upper urinary tract, which could be either a blood clot or a pseudotumor, a hypertrophied papilla, or necrosed or sloughed off papilla. Ureteroscopic exploration in a patient with unilateral hematuria, as seen on this image, in which a tumor was found in the upper tract. Determining the etiology of hematuria originating in the upper tracts, which cannot be diagnosed through other methods like petechial hemorrhages in the PCS. Also, following upper urinary tract urothelial tumors which have been resected. On the left side, there is a recurrent urothelial tumor which has, after conservative treatment by ureteroscopic excision. On the left side, these are calaceal mucosal lesions which are not showing tumor characteristics on narrowband imaging. The procedural contraindications for ureteroscopy are few, and most of them are considered relative, like hemorrhagic disorders, neglected or untreated urinary tract infections, and lack of appropriate antibiotic prophylaxis. Limitations of rigid ureteroscope, as I have previously mentioned, is that there is limited access to the PCS, sometimes need of a stent, difficult access, malformations impeding access to the ureter or sometimes the PCS, and migration of proximal ureteric calculi. The equipment which is required for a ureteroscopy, usually the CM monitor, video monitor, and the lithotripsy device are placed on one side of the patient so that the surgeon's attention on the CM image, endoscopic image, and the laser foot pedal all are in one line, requiring little movement of the head. It is helpful to use the picture-in-picture technology in the fluoroscopy. Preferable to use a flat screen monitor mounted on a swivel arm, and the CM device is usually placed on the other side. Now, two positions that have been described are the dorsal lithotomy and the modified dorsal lithotomy. In modified dorsal lithotomy, either the limb, which the contralateral limb, can be hyperabducted and placed in a lower position, because this allows the ureteroscope to be guided in the direction of the intramural trajectory of the ureter, and the movements of the surgeon are not limited by the contralateral limb. However, some authors prefer lowering the ipsilateral lower limb, because this causes the hemitrigon to be raised, and the abduction of the hip minimizes the angle of the ureter over the psoas muscle. In cases where a percutaneous approach is required, a prone split leg position can also be used. So which scope to be used? So the workhorse of ureteroscopy is a 6-7.5 French ureteroscope. However, in cases where the ureter is narrow, a 4.5 French scope can usually save your day. In cases where the ureter is not opacified distal to the calculus on imaging, and we don't know the caliber of the ureter distal to it, the ureter can be calibrated using a 6 French ureteroscope. The passage of a 6 French ureteral catheter without causing any interception usually implies that the ureteric orifice can accommodate a 6 French ureteroscope. I will briefly brush through the accessories for ureteroscope. The most important being the guide wire. The knowledge of the properties of the various guide wires is important to select the most appropriate type depending upon the desired objective. A slippery guide wire is needed to bypass an impacted ureteral calculus, whereas a stiffer guide wire is needed to straighten a tortuous ureter. The standard guide wire should also have a fairly stiff midshaft to strengthen the ureter to facilitate the coaxial passage of other devices. It should have a floppy tip on the external end to facilitate atraumatic backloading of a flexible ureteroscope if needed. Usually, a 0.035-inch guide wire is used as the initial guide wire. If there is any resistance to the passage, a 5-inch open-ended catheter can be advanced and a retrograde pilogram is done. And once the wire reaches the pelvis, it can be exchanged with a super stiff amplat style wire, which is used as a safety wire. Most guide wires are around 150 centimeter in length, and the diameters range from 0.18 to 0.018 to 0.038 inches. Usually, the 0.035-inch and the 0.038-inch wires are most commonly used. The tip design varies by the shape of the tip and the length of the flexibility at the tip. The shape can be either a straight tip, an angle tip, or a J tip. Most of the times, only a straight tip is required. The angle tip may help to intubate a eccentrically located ureteric orifice, and J tips are beneficial in preventing ureteral perforation because the leading edge of the wire is an elbow, which is less traumatic than the relatively sharper end of a straight wire. They are especially useful in patients who had a impacted ureteral calculus or ureteral tortuosity. All straight and angle tip wires have at least a 3 centimeter of a soft flexible tip. The surface coating for a stainless steel wire is PTFE, and these are the stiff wires. And for nitinol core wires is a hydrophilic coating, which makes them hydrophilic. When wet, these polymers on the hydrophilic wire produce a near frictionless surface and are useful in guide wire passage beyond the impacted stone. However, when they become dry, the wire loses its slippery quality, and the manipulation of a dry wire can easily strip off the coating. Uh, However, this frictionless quality also makes it unreliable as a safety wire because of its tendency to slip out, and it should not be used as a safety wire. So once it is advanced in the renal pelvis, it should be exchanged with a non-hydrophilic coated wire, because this may prevent accident, dislodgement and loss of the ureteral axis. So there are various assortment of guide wires that are available. The nitinol guide wire, which is used to gain ureteral access, to establish a tract, and to assist in the placement, replacement, and exchange of medical devices during urological procedures. The sensor wire, or a hybrid wire, which is two wires in one, like it has a nitinol core and a stainless steel PTFE jacket. The amplat super stiff wire, which helps in straightening tortuous anatomies and deliver heavier instruments. The zebra wire, which is a nitinol wire with striped jacket designed to provide excellent visual feedback while handling. The bi wire, which has flexible tips at both ends, a hydrophilic coating, and a 1-to-1 torque ratio. The wire guide has a straight tip at one end and an angle tip at the other. And the Cobra catheters, which can be used as a torqueable devices, they can be used to guide a wire into specific renal area for delivery of contrast media. So there was a study in which various catheters were studied for their various qualities, and the conclusion was that in general a floppy tip and a nitinol based guide wire appears to be best for access, and a stiffer shaft guide wire is for useful for coaxial passage of catheters, stents, and sheaths. Certain ureteroscope migration devices which are available are the graspet, entrap, the stone cone, and the accordion, and a biogel which solidifies at body temperature and liquefies with cold irrigation. Now, this is a stone cone being used during ureteroscopy. The advantages of all these devices is that when they are withdrawn, the larger fragments also come back along with the device. Various assortment of baskets that are available. Extraction forceps, most of these are 3 French in diameter. They are safer because they allow release in if they are impacted in the ureter. The tri-prong forceps, loops which can be used for extraction of stents or stone fragments. Certain irrigation devices which could be either the syringe style pumps, bulb style pumps like the Pathfinder, hands-free foot pumps, simple pressure bags or pressure irrigation systems, or pressurized irrigation system with concurrent temperature control, which is called the fluid smart. Balloon dilators, most of them are 3 to 8 French in diameter with two channels, one for passage of guide wire, the other for inflation of the balloon. The balloon length is 4 to 10 centimeter and achieves a maximum diameter between 12 to 30 French when inflated. Nottingham dilators, which have conical tips and are progressively advanced over a guide wire. Dual lumen ureteral catheters for passage of two wires. Ureteroscopic biopsy instruments like a ureteroscopic brush, which helps a collection of desquamated cellular material, and cup forceps. Cold knife incision instruments like scissors type of knives or incision blades, which could be either straight, half moon, or hook shape.
Be short now because we are already crossed.
Yes, sir. This is the last few slides, sir. Endoscopic ultrasound transducers, which can be used to detect presence of polar vessels, tumoral invasion depth, or presence of extraureteral migrated fragments. And innovations which have been made are iron oxide microparticles that bind to the calcium component of the stone fragment so that they can be extracted with the magnetic retrieval device. An addition of isoproterenol to the irrigating solution, which helps to relax the ureter so as to facilitate passage of fragments. Thank you and greetings from Goa.
Thank you, Mekhla. It was quite an exhaustive lecture on indications and instrumentations. Thank you for presenting that. All right, let's move to the next speaker. Dr. Fanindra Solanki, Professor and Head at Jabalpur Medical College, NSCB Medical College. Fanindra, are you ready?
Yes, sir.
Please go ahead. Just a request, try and stick to 10 minutes time. Request to the speakers, you can keep your questions ready and type it in the chat box. We will take them up at the end and we can ask them to the respective speakers. You're on, Fanindra. You can.
Sir,
Share. So share your screen, bro.
sir, screen share नहीं हो रहा है. Just a wait.
If there is any technical issue, we can move to the next lecture by Abhay, and then you can. Okay, fine. Is there any?
Just a wait, sir. Screen share.
Fanindra, share screen and then go to the. You open the presentation on desktop. Go to desktop, then you'll see the presentation. Yeah.
Yes.
So, am I audible?
Yes, yes.
So, good evening, everybody. Today, I'm going to talk on semi-rigid ureteroscopy. Myself, Dr. Fadin Singh Solanki. I'm Professor and Head Department of Urology, NSCB Medical College, Jabalpur. See, we already know that semi-rigid ureteroscope replaced rigid ureteroscopy, and we already come to know about the both diagnostic and therapeutic indication of semi-rigid ureteroscope. We all know the simple steps of ureteroscopy. First, we do cystoscopy. We locate ureteric opening. Then we try to put glide wire across the ureter up to the pelvis, followed by the dilatation of the ureteric opening and intramural part of the ureter. Nowadays, with the use of very small caliber ureteroscope, we can skip this step. Once we are inside the ureteroscope, we gently ascend through the ureter up to the pelvis. But we may face problem in any of these steps, like problem in locating ureteric opening. This may occur either because of pinpoint orifice, trabeculated bladder, uretrovesical junction calculus, large median lobe, cystocele, ectopic ureter, duplex system. So this can be taken care by, like in the case of large median lobe, you introduce groove between the lateral and median lobe, and there is a high probability you will directly reach to the ureteric opening. In case of large cystocele, you can reduce the cystocele by putting mop or small mop or large gauge piece inside the vagina, and then you may be able to locate the ureteric opening. Sometimes we ask our anesthetics to inject Lasix, and then we see the jet of urine coming out of the ureteric opening. The best landmark to identify the ureteric opening is interureteric ridge. You can follow towards the required side to reach up to the ureteric opening. When we anticipate this problem preoperatively, we can start tablet pyridium 24 hours before the surgery. So during the scopy, we can see the orange color urine coming out of the orifice. Once we locate the ureteric opening, we can put glide wire, 0.035 inches glide wire across the ureteric opening up to the renal pelvis. Sometimes this also becomes very difficult. So when it is difficult, you immediately empty the urinary bladder. Try to put the tip of the ureteric catheter and inject some dye to know the exact track of the ureter, lower ureter or intramural part of the ureter. And then you can use even J-tip glide wire, hydrophilic coated glide wire to reach up to the pelvis. If it is, even then, if it is not going, you can directly enter with the up to the ureteric opening with the ureteroscope and try to push the glide wire towards the ureter. Sometimes in case of large median lobe, flexible cystoscope can help to introduce the glide wire inside the ureter. If even these maneuver does not help, then you can take a pelvic calycial puncture and try to put the glide wire in an antegrade manner to achieve the this insertion of glide wire. So once glide wire is inserted, ureter dilatation is required, dilatation of ureteric opening and intramural part of the ureter. As I have already told that with the advances, by using 4.5 French, you can skip this step. But if you want to repeatedly go inside the ureter, it's better to dilate the ureteric opening and intramural part of the ureter. This is most commonly done using balloon dilator. This is a diagrammatic view of doing balloon dilatation. We introduce glide wire, then push this balloon dilator over that glide wire and reaches up to the intramural part of the ureter. There is a video showing the same. Ureteric catheter is used to push glide wire inside the ureter, and then balloon dilator is introduced, and it is inflated with the help of 5 French syringe, and it is inflated up to the till it achieves cylindrical shape. If you apply large pressure, you may rupture the ureter at this site. Very close view of dilatation of the ureteric opening. These are the diagrammatic presentation in which way we uses either Teflon or polyethylene dilator or Nottingham type dilator. But these type of dilatation cannot be used in cases of large UV junction calculus. Once dilatation is achieved, you try to introduce the ureter inside the ureteric opening. Once the ureter is inside the bladder, we try to push the superior margin of the ureteric opening with the beak of the ureteroscope and try to enter inside the ureter. Even when after doing all these manners, sometimes it's difficult to enter inside the ureteric opening, then we may try using dual guide wire. This is a diagrammatic view in which one glide wire is already there, and then we push insert another glide wire through the working channel of the ureteroscope, and we try to enter inside the ureter. This is a video showing the same. Glide wire is there, another one is inserted, and ureteroscope is introduced inside the ureter. So once you are there inside the ureter, you ascend very gently along the ureter. You have to keep certain things, that this ureteroscopy should be performed keeping the ureteral lumen in the center of the endoscopic field. And endoscope is advanced proximally only if the ureteral lumen is clearly seen. Don't try to push the ureteroscope against the resistance. If you find any narrowing, you can dilate it using the balloon dilator again. So what difficulties we face while doing this ureteroscopy inside the ureter? It is either because of edema subjacent to the stone, or because of the kink or tortuous ureter, or sometimes you find rigid stenosed area of the ureteral lumen. So if there is a stone, you can reach up to the just distal to the stone and try to insert glide wire by seeing through the ureteroscope. And always try to, if your older glide wire is not going inside the ureteric lumen, immediately changes with the newer one. That will help you in most of the cases. Even if it is not possible, then you may try to take puncture from in the pelvic system and try to push glide wire in an antegrade manner. Or if you not achieve this, you can postpone the procedure and just put a PCN and comes out and then resume procedure after 2 weeks. Sometimes it is difficult to negotiate through the ureteric kink or tortuous ureter. In that case, again, you try to insert glide wire through the kink. Most of the time, you will be able to negotiate the kink. If it is not possible to negotiate, you can pull the kidney from outside towards the upper proximally. That may sometimes straighten the course of the ureter. This a glide wire is pushed across the kink, and then ureteroscope is ascend very gently, and you negotiate the kink and reaches inside the kidney. These are the photographs showing how we negotiate a ureteral kink using glide wire. These are the small summary of what we have discussed at different level: difficulty at the bladder neck, difficulty within the ureter. Now coming to the complication of the ureteroscopy, we are going to discuss only intraoperative complication in this presentation. The iatrogenic trauma represent an important problem with an incidence varying in different statistics between 2 to 20%. With the advances in technology, this incidence has come down drastically because of the use of lower caliber ureteroscope. Ureteral mucosal abrasion occur because of the mechanical forces, but it does not require any treatment per se. Just you come out of the ureteroscope or put a DJ stent that will take care of these abrasions. Sometimes we create false passes while inserting either glide wire or passing instrument through the ureteroscope, or even ureteroscope is inserted submucosally. In that case, you immediately suspect it, come out and try to locate the false passage. If you are not able to locate the false passage, push some dye contrast material and see the actual track or actual lumen of the ureter, and then insert glide wire in that tract, and then finish the procedure and put DJ stent at the end. That DJ stent will take care of all these false passages. No active intervention is required for the same. Bleeding is rare during ureteroscopy, but sometimes it occurs at the level of ureteric orifice or even from the ureter wall. It just decreases the vision, so it increase the flush or increase the water pressure. That will take care. Sometimes it may become severe. Then in that case, you can postpone the procedure, place a DJ stent to prevent the clot colic post-operatively. This is again one of the slightly common complication in which we perforate the ureter and stone migrates outside the ureter. So then you should not try to take it inside the ureter, because your forceps will increase the size of the perforation, and that may leads to the urinary leak or sometimes even retroperitoneal abscess. But very important here, you don't try to extract the stone. You finish the procedure, put DJ stent, and always tell the patient that one of its stone fragments is outside the ureter, so that this should not cause any confusion later in life. This is a diagram showing extrauteral perforation and stone piece migrated. Don't try to extract it inside the lumen. Nowadays, we are very frequently using different laser, holmium laser and thulium laser, that may damage the ureteric mucosa. That may be small damage even up to the large, leading to the large even necrosis of the ureteric wall. This can be prevented by keeping the probe within the away from the ureteral mucosa, and always position it parallel to the wall of the ureter. One of the dreaded and very less common complication is ureteral avulsion, that usually occur at the level of either pelviureteric junction or vesiculoreteric junction, or anywhere if it is strictured, and it is usually occur in hands of inexperienced hands. So don't try to push ureteroscope against resistance. Always keep in mind, you can always postpone your procedure and do it later on. Just put DJ stent and come out. If this happens, you have to take care immediately. I'm not going into a detail of the treatment of this complication, because either you have to do ureteroneurocytoplasty, or you have to do pyeloplasty, or put PCN and later on take care of do ileal reposition of the ureter. So now take-home messages are always use image intensifier, because in our practice, once we start going in different hospital, there you may find places where you may not see arm or image intensifier. Try to avoid doing ureteroscopy in that case. Make sure all accessories are available. You try to use glide wires. Once it is not going, always try to put newer glide wire. That will take care in most of the cases. Dilatation of orifice is helpful. Take measures to improve the vision. Be ready to stage the procedure and put DJ stent and come out. Recognize and correct complication as early as possible, and if required, call for help. Thank you.
Thank you, Fanindra. That was brief and concise. Very nicely spoken. Well, please keep your questions and keep type them in the chat box. Abhay, you can start sharing your screen. Our next speaker is Abhay Mahajan. Dr. Abhay Mahajan is the chief urologist at Sai Urology Hospital. He's professor and head at MGM Medical College, Sambhajinagar, previously called as Aurangabad, and he is our chairman-elect of urolithiasis section of USI. Abhay will be talking on a very simple, a very raging topic: use of holmium versus thulium laser in ureteral stones. Abhay, all over to you.
Thank you. Thank you very much. I hope you can hear me and see my slides.
Yes, we can very well.
Thank you. I'm extremely thankful to Dr. Mukund Nandankar, Dr. Kishore Vani, and also to all the zone council members and for the ureteroscopic stone management. No disclosures. So as you know, we manage stones by either pneumatic or laser lithotripsy. Pneumatic we have always been using since many years, because it breaks the stone with a very simple ballistic mechanism, like a hammer-like effect. And we're using it for impacted stones which are difficult to manage, a lot of ureteric edemas. And for all these years, we are using pneumatic without any problem. It is also very safe and effective, and we have hardly seen any complications with pneumatic lithotripsy. But then why are we changing to some other modality of lithotripsy? Simply because the major drawback of pneumatic lithotripsy is retropulsion of the stone. And this can lead to an additional ancillary procedure, second admission and anesthesia to the patient, and the overall cost also increases. It is very difficult to explain the patient and the relatives if retropulsion occurs, whether you're working in a corporate hospital, or whether you're working in a nursing home, or whether you're working in a medical college, because all these additional factors which are going to have an additional burden on the patient are not acceptable. And because of this major drawback of pneumatic lithotripsy in ureteric stones, we are now, and the majority of the people are now moving to lasers. So now, as you know, there are two lasers which are commonly used: holmium YAG laser. Just to revise the mechanism, and just for the residents and new consultants who are now interested in laser, holmium laser consists of a flash lamp which stimulates the YAG crystals, which is doped by holmium ions. And there are two reflecting mirrors in the cavity of the holmium YAG laser. And this laser beam is augmented by reflecting from one mirror to another mirror. And this augments the laser, which then comes out from the to the external laser fiber, which is then used into the patient's body. So this is the mechanism how holmium YAG laser acts. We now have thulium fiber laser, which has come in a big way, and it is really promising for stone disease. Very good for stone lithotripsy. The mechanism of thulium fiber laser is slightly simple. It doesn't have any mirrors or reflecting mechanisms. There is just a long thulium fiber laser which is doped by silica doped by silica fiber, and this is then stimulated by the diode laser, which is then connected by the external laser, and the thulium fiber laser beam is emitted into the body. Now, I will just like to add a point that this is not thulium YAG laser, which we have been using for a long time. which is used mostly for tissue indications and less commonly used for stone indications. So the mechanism of thulium fiber laser is entirely different than what a thulium YAG laser has. So let us slightly understand what is the difference between the two lasers before we start using the laser in our clinical practice. So holmium laser has got a very, very high peak power, and the pulse which is emitted by holmium laser is not regular. As compared to a thulium fiber laser, if you see, has a very low peak power, and the pulse which is emitted by the thulium fiber laser is uniform and a long pulse. Now let's see what happens with this. If you see the in vitro experiments which were performed for holmium and thulium, the holmium bubble which is created at the tip of the laser fiber is quite huge in diameter, and hence it gives a very large impact of energy on the stone. As compared to the thulium fiber laser bubble, if you see on the right side of the screen, the bubble is quite small in diameter, and hence the impact of laser energy is less as compared to the holmium laser. So this is the major difference that you have to understand, because larger bubble, larger laser energy, so best for fragmentation of the stone where you are using it in kidney or large stones, or if you want to use laser for staghorn and large renal stones. But for dusting mechanism where you want a small energy, a uniform energy with a uniform bubble which delivers a better energy, then it is good for dusting, where it is commonly used for ureteroscopy, either in semi-rigid ureteroscopy or in flexible ureteroscopy, and also for kidney stones where you want a dusting mechanism like minipur, where you don't want to extract any fragments, you want less fragments, you want to evacuate the fragments mostly by the vacuum cleaner effect, and so you want smaller particles of the fragments. So this is the major difference in the physics of holmium laser and thulium fiber laser. Now, clinically, if you just see what happens with a small bubble and what happens with a large bubble, with these cases I'm doing, on the left side, I'm doing a holmium laser lithotripsy in the ureter, mind you, with the same settings with the thulium and thulium fiber laser and holmium laser. And here on the left side with the holmium, you can see larger fragments which are created, which either needs to taken down into smaller pieces, or you have to extract them with the forceps from the ureter. As compared to the thulium fiber laser on the right, where it creates very, very small fragments, as you must have noticed in the video, and there is, in the end of the procedure, hardly any fragments you have to extract after thulium fiber laser lithotripsy. So there was some improvement with holmium laser, as you must have seen, which is known as holmium YAG laser split pulse, which is also known as Moses technology, where there were two bubbles which were produced at the tip of the laser fiber. One was the larger diameter bubble, and through that, another bubble was passed, which then delivered energy onto the stone surface. The advantage of this split pulse was, because the impact of the larger bubble is not there on the stone, the retropulsion of the stone theoretically reduces with a split pulse holmium laser. So this was the difference. In vitro studies then were performed between thulium fiber laser and holmium laser, and you all know this study which was performed by Cronenberg, head-to-head comparison, but this was an in vitro study where the energy in thulium fiber laser is very, very low as compared to holmium. We can have very, very high frequency. The pulse width is quite uniform as compared to the holmium laser. This all culminates into a 4 times higher efficiency of thulium fiber laser in terms of speed, in terms of ablation volume, in terms of producing very, very small dust, and also the retropulsion is significantly less. Another advantage with thulium fiber laser is smaller fibers are available, so irrigation is better, the vision is better, and the surgeon can perform the stone lithotripsy very confidently. So if you see this study, which is compared holmium laser and thulium fiber laser, and if you see the ureteral efficiency was almost the same, but the operative time with thulium fiber laser was less, and the bleeding which lead to impaired vision was significantly less with thulium fiber laser. So everyone is now concerned with the safety of thulium fiber laser. And there were studies which compared holmium and thulium fiber laser in the ureter for ureteric stones, and they found that there was no significant difference in the operative time, stone-free rate, and the complication rate. There was a study from the Nadiad group for ureteric stone with semi-rigid ureteroscopy, and they found that the surgical time, laser time, and stone fragmentation rate was comparable, but thulium fiber laser definitely had better endoscopic vision, less stone retropulsion, and slightly better stone-free rate. So everyone was now concerned with the heat generated by the lasers. It was not that only the thulium fiber laser generates heat, but this was a study which showed that there was a significant thermal response with high power holmium laser lithotripsy, which it was done in all types of stones. So this study then compared thulium fiber laser and holmium laser, an in vitro study, and they showed that thulium fiber laser produces higher intraureteral temperatures, but if the watts is 20 and less, there was no significant difference which was produced in the maximum temperature by thulium fiber laser or holmium laser. And only when the watts went above 30 watts, which is very rarely used, we use 30 watts, we don't use 30 watts in kidney also, so forget about using 30 watts in ureter. But then the increase in the temperatures was 11% in the thulium fiber laser. So everyone, all studies, if you see, which show that there is increased thermal heat generation or thermal effects in the ureter or in the kidney. The most important thing is to maintain a good irrigation during the laser lithotripsy, and this will significantly reduce the complications which can occur on the tissue. We are always concerned with strictures in the ureter, but this was the study which showed that holmium laser lithotripsy also causes ureteric strictures, and this study showed that the thulium fiber laser also caused ureteric strictures. So it is not that thulium fiber laser will cause strictures and holmium will not cause any ureteric strictures. Both lasers are not good if they are not used properly and in a proper way. So how do you use lasers in ureter? So this is what we follow. This is my protocol. Usually I divide this into 3 scenarios. One scenario is a ureteric stone which is lying freely in the ureter with no edema, with no mucosal edema around the stone is not impacted. So in such cases, you can very, very safely use laser and avoid pneumatic. Another advantage, wherever the stone is, whether it is in the lower, mid, or upper ureter, very safely you can perform laser lithotripsy without any risk of retropulsion. So that is the biggest advantage of laser. You can see the stone here in the video is not moving at all. If you use pneumatic here, the stone will go above in the upper ureter and sometimes fly in the kidney. The second scenario, clinical scenario, is there is edema, but more than 50% of the stone is visualized through the mucosal edema. So in such cases, still you can use laser, like you can see the way I am using it. The fiber is focused exactly in the center of the stone. It is away from the ureteral mucosa. So use laser carefully, but if you're not confident and if you feel that the laser fiber is touching the ureteral wall, then you use pneumatic lithotripsy. So both options are possible, but impacted stones, once it gets disimpacted, then again it will start flowing back into the upper ureter and the kidney. So it is safer to use laser if more than 50% of the stone surface is visualized in the ureter. Coming to the third scenario, where there is a lot of ureteral edema, you can hardly see the stone surface, or it is less than 50% of the stone surface which is visualized, then it is always safer to use pneumatic and not to use laser in such cases. Another tip or another trick which we use is we disimpact the stone with pneumatic. So we use pneumatic probe, disimpact the stone. We push the stone into the proximally dilated ureter, and then to avoid retropulsion, we use laser lithotripsy once it is lying freely into the proximal dilated ureter. So there is no risk of ureteral mucosal injury, and you can safely perform laser lithotripsy. So these are our recommendations. Always use in fragmentation mode. Why? Because the frequency is less, so the amount of heat generation is less if you use in fragmentation mode. I usually use the setting of 1 joule and 6 hertz, that is total of 6 watts. Never ever go more than 10 watts in ureter. You can see the Western literature where they have recommended to use 15 or 20 watts in the ureter, but that is not at all advisable. We stick or we restrict our use to only 6 watts and not more than 6 watts. Always start from the center and then go to the periphery. This avoids good mucosal damage, and if it is an impacted stone, then it is better to use pneumatic rather than to use laser and risk the ureter for further injuries like stricture or thermal damages. Thank you very much.
Thanks, Abhay. Thank you for that clear-cut guidelines. Amit, you can start sharing your screen.
Yes.
If there are any questions, please post them in the chat box. Our next speaker is Dr. Amit Sharma. Amit is professor and head at All India Institute of Medical Sciences in Raipur and Chhattisgarh. Amit, please start sharing your screen.
Thank you, sir. Hello.
Yes, Amit, you're audible.
Sir, is the slide visible?
No.
No, sir.
Amit is speaking on flexible ureteroscopies.
Yeah.
With the most commonly done procedure. Amit, now slide is visible. You can start.
Okay, sir. Thank you, sir. First of all, I thank Mukund sir and Kishore sir to give me an opportunity to talk about the flexible ureteroscopy. Most of the things I've already covered by Fanenda sir, Abhay Majan sir, and Dr. Naik about the ureteroscopy, different types of lasers, how should perform the ureteroscopy. My topic is about the flexible ureteroscopy. It is divided into 3 parts: equipment and setup, basically on the types of the flexible ureteroscope, both digital and fiber optic. Role of ureter axis sheath in RIRS, and role of suction, both fan and versus disc. As we all know that RIRS is recommended for the stone, renal stone of less than 2 centimeters in most of the guidelines, but there are certain challenges with the flexible ureteroscopy also. As we need to have a good optics, so to visualize even on a bending, have to stand with the excessive torque for the prolonged period. Regarding the instruments for the RIRS, depending upon the availability of whatever the available in the market, energy sources, holmium, TFL, flexible accessories, various guide wires, dilator, axis sheath, graspers, ureteric catheters, and forceps, suction pump, video camera unit, and fluoroscopy unit. Newly designed flexible instruments with a dual deflection, standard fiber optic scopes having a tip size ranging from 6.7 to 9 French, active deflection with 120 to 170 degrees, and secondary deflection with a passive or active movement. Active secondary deflection allow the better maneuverability. Working channel are usually 3.6 to 4 French, and standard instruments are 2.2 to 3 French, depending upon the manufacturer. Energy source, already Abhay sir has told about how to use the holmium fibers or TFL, what are the settings and how it should be done safely to avoid injury. This is basically a trolley for the RIRS. Here we can see a digital scope, cystoscopy instruments, ureteric axis sheet. Basically here is a fan sheet with the suction for the collection of the fragments and ureteric catheter. Regarding the patient position, I recommend that RRS should be done in the general anesthesia so as to avoid the movement of the kidney during fulguration, so that we can prevent the injury to the kidney and bleeding. Ideally, patient is kept, after anesthesia, patient is kept in the supine position with abduction and external rotation at the hip and the knee joint. There should not be too much of external rotation of the knee and hip, and all the pressure points should be well padded. Regarding on the left side, the legs should be kept a little away so that the trolley, which is where the instruments are kept, can be kept under the that leg. Regarding the camera system, it should be on the left side. It should be ideally it should be at the eye level, so that there should not be a too flexion or extension of the neck, and so that we can avoid the neck straining. Regarding the who is assisting, he should be stand behind the right hand of the operating surgeon, so that there is no crossover the hands during the surgery. Regarding about the scopes, digital versus flexible fiber optic, there are certain things common between these two scopes. As optic view is 0 degree, as you all know, working channel is 3.6 French, and it can be on 3 o'clock or a 9 o'clock position depending upon the manufacturer. First we talk about the fiber optic scopes. The fiber optic scope usually contain multiple fiber optics in the case that relay the image in the same orientation and perception. As we can see from this image, that there are multiple fiber optic fibers that relay the images to the camera system. But there is some problems occur with the fiber optic scope, as there are multiple fiber optic fibers. It leads to more effect, honeycombing. If there is a damage to one of the single fiber, it will create a black dot on the screen. As we can appreciate from this figure, that with this fiber optic bundles, there is a more effect, honeycombing on the images. While in the digital scope, image is processed to either CCD or CMOS. Basically, these are the sensors present on the tip of the scope, where both camera and the sensor are at the tip, that make the scope lighter. Here we can easily appreciate the image on the left side. You can see the image from the fiber optic scope, where it is a blur with some honeycombing. There on a B image, there is images taken from the digital scope. As it is very clear, there is no honeycombing effect. Same what I have previously told, that if there is a damage to the fiber, you can see the black dots there, and their image is not also very good as compared to the digital scope. Here are the two pictures, side-by-side pictures of fiber optic and digital scope. On the left side, there is a digital scope. You can see it is less bulky, as the camera and sensor is at the tip of the scope. On the right side, you can see the fiber optic scope with the camera headlight. All the bulky things are on the scope. So if the surgery is prolonged, there will be a fatigue to the hand, and vision is also not good as compared to the digital scope. Digital scope, as there is a camera and sensor at the tip. Usually digital scope will have a more diameter at the distal point, usually 8.4. Recently there are some manufacturers who are claiming that they have a smaller size scope, like 7 French, while as the fiber optic scope don't have a camera or a sensor at the tip. So the distal tip is less than 7.9 French. Recently there are some scope having the size of a 6 French. This result, due to this features, the fiber optic have a better angulation in the lower calyx, especially in the lower calyx. To summarize the difference between the digital and fiber optic scope, in fiber optic scope, there is a reduced image resolution resulting in a more effect of honeycombing, longer operating time, due to camera head and light source. There is fatigue to the hand. But there is a decent advantage that tip is small, better access to the lower calyx. While in digital scope, there is a better resolution because of the improved vision. There is a shorter operating time. All the things are integrated in the scope itself, resulting in the lightweight of the scope. But as the size is more, it is difficult to maneuver in the lower calyx. This is one of the table of the different companies about their optics, models, working length, how is the diameter of the distal tape, proximal shaft, degree of the rotation, primary and secondary. There is a certain problem with the reusable scope, or we can say a fiber optic scope. Usually, there is always a wear and tear of the scope, most commonly at the shaft of the scope. There is still now debate how to sterilize this reusable scope. The operating time is long due to poor vision or due to multiple uses. There is a problem in the deflation also. There is obviously there is a initial cost of to acquire the instrument. Now let us talk about the ureteral access sheath. Briefly, it is consists of the two parts. One is the outer sheath, usually having a hydrophilic coating, inner insert, having a smooth taper tip for easy insertion into the ureter, automatic insertion into the ureter, having a distal hub with lever lock for engagement into the sheath. Sizing. Regarding the ureteral access sheath, sizing, diameters, length, usually it is available in the size from 9 French up to the 14 French. Length, various sizes are available, like a female sheath of 35 centimeters, male sheath of 45 centimeters. Most commonly used sheath is 10 by 12 because of easy of placement and irrigation. If we are at all using a smaller scope, smaller sheets are available in the market, like 9.5 to 11 French. 12, 14 French can be used, but the problem with the 12, 14 French is that the patient should be pre-stented. Otherwise, there is an increased chance of ureteral injury. The important factors should be considered while placing the ureteral access sheath is that it should always be done under urological guidance, like fluoroscopy. It should always be done over a glide wire. It should be smooth. There should be the insertion should be smooth. It should be automatic. If at all we are feeling a resistance during the putting the access sheet, never ever force to place the ureteral access sheet. Otherwise, it will cause an ureteral injury. There are certain problems with the wrong sizing of ureteral access sheath. You can easily see from these figures, like depending upon the grade of the injuries. So there you can see the mucosal injuries. You can see complete perforation in the figure C also. What are the advantage of lastly regarding the suction devices? So this is one of the study where 31 patients were taken and 10 French fans was used. There was stone-free rate of 98% after 24 hours. It was able to access all the lower wall stones, and there was no additional procedure required, and no infection complications was noted in this study. What are the problem with the current ureter access sheath is that most of the time it is not possible to access all the part of the kidney, and there is a problem to remove all the fragments and the dust. So what is the role of a suction? At present, there are two types of suction devices. One is direct in scope suction device, and there is another flexible access navigation sheet. Already was stated that what are the problems with the ureteral access sheath. The solution for this is suction with the scope, or suction with the ureteral access sheath. There is shift of the piegram in the stone management from fragmentation, basketing to dusting and section, reduction in the number of the stage procedures, and we are trying to just make the procedure as an outdoor basis. They are the recent 16 meta-analysis comparing comparative study where various section devices were used. According to this study meta-analysis, there was improved in the stone free rate, reduction in overall infection and complication rate, and there was reduction in the duration of the hospital stay. A little bit about the direct in-scope suction devices. This is by Fusion. It is 7.5 French scope with working channel of 3.6 French. There is an inbuilt suction and can activate laser with the suction at the same time and can aspirate dust up to 215 micron. It also decreases the intrarenal pressure and intrarenal temperature and minimizes the snow globe effect. Advantage is allowed to remove the derbies during the laser surgery, minimizes the visual loss through the snow globe effect, reduces the intrarenal pressure and temperature. The problem with this direct in-scope suction device is that the size of the dust, it should be less than 250 micron, and there are multiple ongoing multicentric studies are going regarding the outcome of this disc. Role of the suction, this is flexible and navigational suction ureteral axis sheath. Basically, it is a generation 2. The main advantage of this sheath is that it is having a flexible distal tip for easily maneuverability in the kidney with the hydrophilic coating of outer sheath. There is a rubber seal to ensure the air tightness and prevent leakage. This is the difference between the first generation and second generation fan. And there is an oblique slide for the connect to the section jar where we can collect the dust and the stone fragments. The mechanism of fan is that there is an inflow of an irrigation through the endoscope. The outflow of irrigation is between the scope and the sheath. This creates pressure, and at the distal end of the sheath, the irrigation fluid and stone fragment, dust, blood, whatever the things are there, get aspirated through the sheath. The pressure of the vent on the oblique side branch of the sheath can be adjusted as per the requirement. Advantage that it can advance past the UPG, navigate all calyxes, remove dust, derbies, and the stone fragment, reduces both intrarenal pressure and temperature, decreases the operating time, and he's having the lower complications rate. Same, there was a study, sorry for that slide was previously, it should become here only. It was done on the 30 patient using the 10 French sheath. The conclusion of the study was that stone free rate was 98% after 24 hours. They were able to access all the calyx, including the lower pole one, and there was no infection complication in all these 31 patients. There is certain limitation of fan also. It is not possible to clear all the fragment and dust, and sometimes it was not possible to access all the part of the kidney as per this study. Finally, finally about the fan, already stated, suction devices using the ureteral axis sheath can reach the lower calyx, can aspirate that is having the advantage over the direct scope suction, that it can aspirate the stone size of more than 250 microns. And there is a well-established clinical trials regarding the fan, but with direct in-scope suction, the fragment should be less than 250 microns, and there is ongoing clinical trials on this. To conclude, the suction in the RRS show the promised result in improving the outcome, the potential for expanding indications and complication, future prospect with ongoing research and innovations is required. There is a need for more robust evidence and standard these things, and importance is of proper training. This all whatever that we are talking about, the fan or direct in scope suction device, required a certain amount of the training. Finally, the thing is that in endourology, there is no such thing as never, and there is no such thing as always. The important of thing is that whatever the things we are using for the stone management, it should be individualized as per the patient, as per the stone. Most importantly, in a country like India, it should be cost effective, because each and everything, whatever you're talking last 1 hour, required some cost. And as we know, most of the patient in our countries belong to the poor strata, and most of the things what we are doing practically, they are in some yojanas. So it become very difficult to manage all these things in that cost. Thank you very much for this.
Thank you, Amit. Thank you for that exhaustive discussion on fans and this, which is the most important and topic of today. Abhijit, you can start sharing your screen.
Yes, sir.
Our next speaker is Dr. Abhijit Patil. He's a consultant urologist at Mulji Patel Urological Hospital, Nadia, Gujarat. And he's talking on the future trends in ureteroscopy. What are we looking at? Abhijit, all yours.
Yes, sir. So is it visible, sir?
Yes. You are, screen is not yet visible.
Now is it visible, sir?
Yes. Yeah, go ahead.
Well, thank you, sir, for this opportunity. So the talk is divided into three parts. So first is for tips for reducing cost, the reprocessing and sterilization. Then we will look something about what is robotic RRS and what is AI in endourology. So flexible ureteroscopy first started with reusable flexible ureteroscope. Then it shifted to single-use flexible ureteroscope. Then there is something known as multiple-use flexible ureteroscope, where it is actually a disposable scope, but it is used as much it can withstand till it breaks. So there is no repair in these scopes. Can we really act? So this talk is basically for residents, so they need to know, can we really reuse these single-use devices? Yes, this is a white paper from Joint Commission International, where there are certain things that you have to take care, whether the effects of cleaning, disinfection, and sterilization that you are going to do to the device, will it affect the function? Will it change the design specifications? And will it change the functionality or the performance of the device? And in case there is an adverse event, can you actually find a patient who was affected with this? Can you trace the patient? And if you want to do this, you should have a reuse committee in the hospital which establishes policies, regularly modifies them. There are written protocols and which are validated at a regular intervals. And there is a quality assurance. Once if you achieve each and everything, then yes, you can use reuse the single-use devices. So this is a real-world data which was gathered by many urologists. Some of them are actually Indian urologists from around 2,000 odd patients, where they evaluated reuse of this single-use disposable scope. The outcome, or what they say, is that it is a cost-conscious approach, but it has a low rate of serious infection, but a high rate of residual fragment. So what is study concludes is that if the scope is defective, it is counterproductive for patients and surgeons, because any damaged scope would prolong the surgical time and increase the residual fragments and eventually risk of infection. So what the study says is that don't use the scope till it is too much of damage. You can use the scope where till the point where it is safe for you and your patients. Now let us understand what are the different ways of sterilizing things. So there are sterilization is the best way because it kills all the type of organisms, but high level of infection that you see will not cover the bacterial spores. Rest it will cover everything. Now this is a Spalding classification where does our flexible endoscope is in a semi-critical category, where it intends to come with just contact with mucous membrane. So the pre-processing procedure which is required is either sterilization or high-level infection. Now what is high-level infection is the Sidex or OPA that you use. And sterilization could be low temperature hydrogen peroxide glass plasma, which is commonly known as STERRAD, ETO, or STERIS. Now, yes, we can actually use it in Sidex OPA. This is a high-level disinfectant, as I said. It is bactericidal, tuberculosis, virucidal, fungicidal. It will not kill spores, but rest it will kill everything. And it says that, so plain Sidex, the holding time is 20 minutes. But for Sidex OPA, as you can see, this is from the official website, it is 12 minutes at the room temperature. So minimum 12 minutes is required. So this is a prospective comparative study whether your flexible uteroscope is sterilized is used with Sidex OPA versus Starad. So this actually study said that if you use a scope with a Sidex, its life improves. So it says that the durability and longevity is strongly related to sterilization method, and this study concludes that Sidex should prioritize steroid in sterilization of DFU. That is the outcome of this study. I will tell you how to use high level disinfection. Second part, how to use steroid. So how to use high level disinfection, as most of the people would be using Sidex OP in the prior practice, is once your scope has been used in the case, you should clean the scope and all the accessory immediately. You should do a leak test. You should clean the manual outside exterior of the scope and also the channel with either plain water, or if you have enzymatic detergent, it is highly welcome. Then you have to dip everything into high level disinfection like a Sidex OPA. Once you have kept in, suppose for 12 minutes, then you clean with clean water, you do a force air drying, and then you keep it stored for the end of the whole day. And then when you use it for the next day, you can again put it in. I will show you in the next slide. So these are the process. How do you do it? So this is the first thing, is you just fill it with normal saline. You see, it is just free from the exterior, and then you, with the 50cc syringe, you will flush out all the debris, the blood, clots, and everything will come out from here. Followed by, what you do is, if you have a brush, then you put it through the channels, all the fragments, one fragment, mucus, clots, whatever it will just come out of this. So this is how you completely clean it. And now once that is done, then you again flush it with water so that there is no final anything inside. And this is how you should have a high pressure air. So we completely clear the channel of any fluid inside it. And then you put this whole scope, except the point where you your monitor, you insert completely into the high level disinfectant solution that you are using. That is how it works. Then, as you see, if you see this, so it says that this cap has to be attached if you want to immerse it in the cleaning solution, or it has to be removed if you are using in a Starad. So these are the 2 points that you have to understand. If you are using Sidex, close it. If you are using in Starad, open that cap. So once you have done this at the end of the day, the next day when you have to use it, what the pre-use is that you again dip the whole scope into high-level disinfectant with the scope and cable. Then you remove it, you clean it with normal saline, you forced air dry everything, and that is where you can again go into the patient and operate it. So there are certain scopes, as you can see, where they say that, so this whole scope can go inside. You just remove this and you can apply a cap over there, and that is how you can dip it completely into the Sidex. This is how a Starad is used. Packet in a packet, and then you will place it in a Starad machine as it is present over here. So these are the various cycles which are present, and generally the cycle that we will use being is a flex cycle, which is of 42 minutes. So if you have suppose 2 scopes and you want to do a third case, then probably you put the scope into the Starad and you flex it, cycle it for 42 minutes, and then the scope is available for you for the third case. Now, what are the tips for the residents or the new consultant neurologist to minimize the flexible rotor damage and improve the durability is, so there are various things that you have to understand. Before you use the scope, check the external vision and optic fiber damage. Check the laser fiber damage. If there is a damage in the laser fiber, it will damage the scope when you are firing it. Intraoperatively, it is better you start with semi-rigid URS because it will help the calibrate the ureter and especially dilate the lower ureter. Keep flexible uteroscope as straight as possible. Ensure adequate lubrication of that scope. Use a well lubricated glide wire. If you want to backload this flexible otoscope, gently manipulate this deflection lever. Don't be in a hurry to manipulate it. Avoid long duration. So if you are doing a larger lower pole stone, don't keep on flexing it for long time. you lace the stone, make small fragments, you try to retrieve it and send to a pelvis or upper calyx, where the scope would be slightly straight, and it will there will be less damage to the scope, and you ensure that the ural axial sheet tip is not causing damage to the deflection of the scope. So it should slightly be below the pelvic junction, and then the flexion can be done properly. Use a smaller laser fiber diameter. Keep the flexible ureteroscope straight in neutral position when you are inserting the laser fiber. Otherwise, it will damage the channel from inside. Avoid fibering the laser fiber in the scope channel. It will damage the optics of the scope. Post-operatively, always do pressure leak test after each case. Adequate awareness and training of the sterilization staff, because you cannot do it for every case. So you do a proper training of your staff, and keep a proper storage of the scope. So you can have, if you're in a teaching institute, you can have two scopes, one for resident, other for consultant. The higher you scope, where the deflection is lost, you can use it for the cases where there's an upper calyxial stone or a pelvic stone. And if there are lower calyxials, you may use a fresher scopes unit, clean and dry the channels properly, and sterilize the scope properly, which will reduce the acquired infections. So this was the reuse and how to maximize the use of the flexible ureteroscope. Now some history, robotic flexible ureteroscopy. So it all started with the first flexible ureteroscope. So basically flexible ureteroscope robotic way is actually a normal flexible ureteroscope which is manipulated robotically. Okay, so as you can see, there is this company from Turkey which is known as Elmed, which is working a lot on this flexible ureteroscope. As you can see this, there is a ureteroscope which is mounted to a robotic manipulator. So this is a robotic manipulator. This is a flexible scope it is attached, and this is the foot switch from where you can either control the fluoroscopy or control the laser findings. And this is a small video where you can see, so this is the ureteral access sheath which being present. Then you drape the robot, and once the robot has been draped, then what you have to do is you dock the robot near this access sheath. Your access sheath has been will be docked to your robotic arm. Once this is done, you insert a flexible ureteroscope, and this is the device which will actually keep the ureteral your scope straight. So you insert it, your scope goes through it, and once you dock it, what will happen is that it becomes straight. Now this is a side channel from which this is the irrigation which is attached, and then this is the manipulator, the laser manipulator which is attached over there. Now, as you understood, this is a normal fiber optic flexible ureteroscope which is just attached to the system, and then it is just a manipulator. And once this is done, a surgeon can sit. So the benefit of this is that you can sit and outside the OR, which will decrease your radiation exposure. And once this is done, so this is how once you manipulate your arm, this will keep on rotating and do the movements. Some benefits are that you can, if you are doing a difficult case, you may get fatigue, but with this robot, you can have that robot in a fixed position without having yourself a fatigue. So this is how your surgeon console looks like. You can adjust each and everything, the fluoroscopy, the lie of the scope, the energy setting there. So this is a 360 view of the OR where you have everything. The surgeon is sitting over here, and then this is the footpad, as I said, which you can control the laser as well as the fluoroscopy. And then as you can see, so the left hand controls everything, and right side is like a joystick, and it can flex, deflex, and the left side will control in and out. And that is how you can do a proper laser lithotripsy in this case. There's a new company from France which is known Starlab. It is again doing the same thing. As you can see, the surgeon sitting with a joystick and is controlling the flexible ureteroscope and manipulating inside the patient. This is something new. This is again company, and you can see the developed robot where joystick which the surgeon will try to control. So once he controls the system. Now this is something the scope movements will be this way.
Could you put the volume of your video so that your speech will be loud?
This, am I audible now, sir?
Yeah, now it's audible.
You see, with the respiration, your scope keeps on moving, and if you fire the laser, it will injure the pelvic hallucinal system. Now, if you switch on the respiration sync, what happens is that your scope also syncs with the tidal volume. Now, as there is no relative motion, your stone becomes fixed, and that is how you can precisely laser and do the surgery very fast. And this is how it is. You can deploy a basket, and as you see, now you can decide. So as you see the stone size that you have seen, there is a size guide. As if you try to grab a stone which is slightly bigger in size of than your ureter, the ureter get avulsed. Now that is how it gives you a size guide, and at a click of a button, the stone comes out with the basket. So that is how advanced are this robotic flexible ureteroscope. For the understanding of the resident, you have to understand that the scope is the same that you are using. It is just manipulated robotically. Okay, so now last aspect of the talk would be artificial intelligence in endourology. For the resident to understand, it's artificial intelligence is the bigger gamut, out of which is machine learning. Machine learning means there are algorithms whose performance improve as they are exposed to more and more data that you feed the system. And then comes the deep learning, where actually and the newer things are coming into picture, is where there are a lot of neural networks which are added using the vast amount of data that you have. Now, where can we use it in urology is either detection of stone disease, prediction of management outcomes, optimization of operative procedure, or analysis of the stone. So that is where you can use it in endourology. How AI works is that it starts with data collection. So as human, you have to feed the system data. It will not gather it from somewhere. So you have to feed the data. Then the data is collected and cleaned up and organized very effectively. Then you give the machine a training model. So the machine learns, that is not machine learning. Then after evaluation, the model is tested for the new data that you give. And then you fine tune the data, and then you deploy it for the real world use. So that is how this AI algorithm works. So now either it could be virtually, where you can see the stone composition and the outcomes of the disease, or it could be physically, where it could be integrated into physical things like robotics and nanotechnology. Now coming on to endourology and especially stone disease, how and it change. So based on the old data that you feed, and then are the various algorithms that are prepared, you can optimize the stone detection by various imaging modalities, be it be CT, ultrasound, and X-ray. So once you feed a CT to suppose an algorithm, it will detect whether the stone is there or not, the size, location, and everything. So especially where there are no experienced radiologists, you can get a proper diagnosis of the stone. Then there are, so you feed all the data, the stone, various patient parameters, location of the stone, hardness, and everything to the system. And then by AI, you can optimize the ESWL protocol, as it will give you, so you have feeded everything. So now personalized to that patient, it will give you the best ESWL setting as to what should be the power, the shock wave rate, the total number for each of the steps for every ESWL session, based on the data that you have fed in the last in the previous data where you had a good outcome. So it will help predict you have a better outcome in your treatment. So suppose you have a stone and you have a lot of other parameters which you have fed to the system, and then it will tell you what is the stone outcome. So whether this patient you operate with PCL, what would be stone free rate in this patient. So that is how it helps you predict the PCNL outcomes. And again into, so they do give a lot of data to the patient in the system, and it will tell you what would be the chance of recurrence in this patient. So that is how it helps you take the decisions. And then finally, what AI is going to do is it is going to be integrated in your flexible ureteroscope. And so there is something known as convolutional neural network. So it works basically on your image. So as you have Google search, so you feed an image, it will diagnose the things in the image and give a similar picture. So what you have fed the system, that if you see a stone like this, it is monohydrate. If you see it like it is dihydrate. So now the machine learns. And now when your flexible ureteroscope goes sees the stone, it understands from the previous data, yes, that this stone is of this composition, and then it can automatically give you the best laser settings for this stone. So you have worked hard. So this is how it works. So you feed the images to the system. There is something like CNN and the various algorithm, and that is how you can actually, the devices in which this AI is integrated, it will help you take a better decisions. So as you see, there are 222 AI-based medical devices approved in US and 240 in Europe. Okay, so urology is slightly behind because radiology has the maximum devices of 120 followed by cardiology, neurology. But I think AI will soon come into urology in the form probably integrated into flexible ureteroscopy, where it will tell you the intrarenal pressures, the intrarenal temperatures, the stone composition, and the best laser settings available for it. And then finally, if the patient comes to you, he wants to know whether what are the chances of stone recurrence. You feed the data to the system and it will tell you what are the chances of stone recurrence in this patient. Thank you. And that is how artificial intelligence actually makes you wiser in taking your decision and helps you in clinical judgment. Thank you, sir.
Thank you, Abhijit. The future does look very exciting. Well, that brings us to the end of this webinar. Over to you, Kishore, if you have time for any questions or.
There are a few questions which are coming in chat box. The first question is for Dr. Mekhla Naik by Dr. Prashant Mulawkar. Do you put safety guide wire all the time? Is it necessary? Is Dr. Mekhla is there or she left?
No, she's
She's there, yeah.
Hello.
yeah,
Yeah.
Mekhla is already
Yeah.
forward.
The question is, do you use safety guide wire in all your URS cases?
At our institution, all our patients are pre-stented. We use only one glide wire for the ureteroscopy cases. Only if there is difficulty in navigation of the ureter, then we use a second wire.
Okay, thank you. The second question is for Dr. Farindra Solanki. How to manage a circumferential mucosal avulsion?
Circumferential mucosal abrasion. So we always try to find the opening in that circumference. Most of the time we get that opening, and then we try to introduce a straight tip hydrophilic glide wire through that opening, and then we put DJ stent and come out. But you have to give time to find out that opening.
So once you put a stent inside, you may keep it for 6 weeks or 8 weeks. Do you do ureteroscopy after removal of the stent at the follow-up?
Sir, I have done only once this circumferential injury. I was not able to take out the stone that was in the lower ureter. Then I kept DJ stent for 2 months, and then redo the ureteroscopy. Everything was fine. Immediate post-operatively period that the patient developed high-grade fever that persisted for 72 hours. So I have to manage it by using different antibiotics and anti-inflammatory.
Thank you. There's a question for Dr. Abhay Mahajan.
What if the wire doesn't go?
Sir, then what I can think is then you have to do in an antigrade manner. That immediately will go because the circumferential flap will prevent the retrograde insertion of the glide wire. Antigradely, you can always put it.
There's a question for Dr. Abhay Mahajan. What is the ideal laser setting for either holmium or TFL in impacted upper ureteric stone to avoid stricture?
Yeah, so this I have already mentioned. We use 1 joule, 6 hertz, a total of 6 watts power, whether it is holmium or a thulium fiber laser. I don't think we should go above 10 watts. Say the stone is very hard, the HU is more than 1200 or 300 units. Then you can just go till 8 watts or rarely 10 watts, but 6 watts is most of the time sufficient.
There's another question. Even laser can cause retropulsion. How to avoid that?
Yeah, laser can cause retropulsion, but if you compare with pneumatic, the incidence of retropulsion is significantly less with laser, more with pneumatic. And secondly, the irrigation fluid should not be forced irrigation. It should not be pressurized irrigation. So if you are putting a lot of pressure on the irrigation bag, then definitely any stone will retropulse in the kidney. So regular irrigation will avoid this. with
Thank you.
laser.
There's a question for Dr. Amit Sharma. What is your choice, disposable versus reusable?
For me, disposable is better, as I am working in the teaching institute.
For the private practitioners who are freelancing?
Freelancing also, I will recommend disposable because of cost and vision also.
Conventional versus fans?
If at all fan is available, fan is better than conventional for a stone clearance.
Thank you. Thank you, Amit. Thank you so much. Abhijit, what is the future of robotics in India? Robotic FERS in India?
Okay, so as we saw, sir, so these are not a true sense robotic flexible ureteroscope. They are just manipulators. So there are new companies coming into scene. As India is, as you see, all our things are cost constrained, and probably our surgeon as equivalent to a robotic flexible ureteroscope. I think it will take a lot of time for robotic flexible ureteroscopy to come to India and be in a regular practice.
Thank you. Thank you. At the end of the session, I would like to thank Dr. Mukund Andankar sir for taking his busy time schedule and attending and making all the program and all the chapters and all the lectures on this ureteroscopy webinar. Thank you, sir. Thank you so much for that. I also like to thank all our faculties, Dr. Mekhla Naik, Dr. Fanendra Solanki, Dr. Abhay Mahajan, Dr. Amit Sharma, and Dr. Abhijit Patil for the wonderful talks. And really, they gave a lot of insight and justice to the topic that they had been given. I'll also like to thank all the participants for this webinar for attending this long hour webinar on ureteroscopy. But I think you will have some carry home take home message at the end of the webinar. Lastly, I would definitely like to thank Wisdom USI Council for giving me this opportunity to, as a convener, to conduct this webinar. Thank you so much, everyone. It was a wonderful event. Thank you, everyone. Rajesh bhai, is there any?
Sure.
No,
Thank you.
no, thank you, Kishore, thank you, Mukund, and thank you all the participants, all the faculty for their excellent talks, and thank you all the delegates who attended this also. And if there are any more suggestions we can improve in our subsequent webinars, please do let us know, either of the council members, so that we try and increase the standard of the meetings. Thank you very much for all. Thank you, Kishore, thank you, Mukund.
Thank you.
Thank you so much. Thank you.
Thank you, sir.
Thank you, everyone. Thank you very much.
We can close down the meeting.
Yes,
Thank
sir. So the live stream has stopped, sir.
Yes.
Thank you, sir. Thank you, everybody.
Thank you so much. Thank you so much. Bye-bye.
Bye.